Hi, I'm Amir Marvasti. I'm a cataract, cornea, and refractive surgeon based out of Orange County in California. And over the next 10 to 12 minutes, I'm going to talk to you about a topic we're all very passionate about, and that's the topic of advanced intraocular lenses. I'd like to change the framework from what's the best lens to what's the best strategy for the particular patient with the particular eye anatomy and expectation and needs that you have in front of you. We always get asked, what's the best intraocular lens? And I say the best lens is the one that aligns the optics, the biology, and the psychology of the patient all at the same time. So that means we have to have a very deep understanding of the optics behind these lenses, the ability to capture and diagnose, educate, and counsel our patients on any and all of their eye comorbidities, particularly the ones that may affect their final vision outcome. And finally, and I would argue most importantly, the ability and willingness to listen and understand their expectations, the demands of their vision. Quite simply, what makes them happy? What does improved vision mean to them? And how do they plan to use their eyes and vision after the surgery? And I don't think there's any diagnostic test or questionnaire that's going to replace having that conversation with our patients. And only when we have all three boxes checked, we can begin to create a list of strategies for our patients. Now, as cataract surgeons, we're so lucky. There's a growing list of lens technologies that we have every month and every year. It seems like there's a new advancement. And within each category, the companies are really pushing the boundaries of these technologies and lens implants to the point that we have so many choices to personalize and fine-tune and customize the vision for each individual patient that we have. That's the positive. But a potential negative could be having so many choices. Because with choice comes responsibility and uncertainty and fear sometimes. Fear of picking the wrong strategy for a patient, taking them through their vision journey and having a dissatisfied patient despite a perfectly performed surgery. And from a patient's perspective, fear of regret. This is more often than not a once-in-a-lifetime event and surgery for them. And it's a very unique sense, our vision. So what if they are not happy with their final outcome, regretting their choice of lens implant? So it could be a fearful decision. So to me, interventional mindset has one of two components. Number one, developing a lot of comfort as surgeons with a potentially uncomfortable idea of choosing a vision strategy, something that they're going to live for the rest of their lives for them. Or if we have multiple choices, how do we help them navigate that choice? And second, not to box ourselves and our practices and our patients into one or two favorite lens categories we may have, stealing away from some of our other patients another lens technology that they may have done better with if we were just more open to using the different technologies. When I go to the surgery center I go to and I see a surgeon with a list of patients that has all the different lens implants for the different patients they may have, I know that they took the time to listen and understand and truly personalize their patients' vision outcomes compared to choosing one or two category of lenses for 80 or 90% of our patients. So I'm going to talk to you about three lens categories today: the EDOF or enhanced depth of focus, the multifocal or diffractive lens technology, and finally the adjustable lens. And within each category, I will talk to you about my approach, some pearls, and a typical patient I may choose that category for. Starting with the EDOF or enhanced depth of focus. My approach is what this lens does not do is both its strength and weakness. It does not cause classically dysphotopsia, glare, halo, starburst, or at least it's comparable to a standard single focus or monofocal lens. So for someone who's very risk averse, for someone who wants a range of vision without having to compromise quality of vision, especially at night, or they're not going to be tolerant to some imperfections in their vision at night, this is a good choice. It also does not produce consistently good unaided reading vision. So for someone who wants to read without glasses, someone who wants the full range of vision, spectacle independence, this may not be a great choice. Some pearls about this technology. It is more forgiving compared to a diffractive lens to minor refractive misses, minor residual astigmatism, minor ocular pathology and comorbidity. It's not immune from it, You will have patients who have some maculopathy and optic neuropathy that ended up affecting their final outcome. And from a patient's perspective, may get blamed on the lens. So it's still important to screen and choose patients carefully for this technology. It's more forgiving to pathology, but it's not immune from it. A typical patient I may choose this lens for is someone who values a range of vision. They want to have good unaided far and mid-range vision. They do not mind a reading glasses. They're tolerant to that, but they don't want to compromise their night vision or having night imperfections in their vision. Out of most unhappy EDOF lenses, most of them are probably not happy with their reading vision. They probably had higher hopes for their reading vision than what they ended up with. So really talking to them about and counseling them on the fact that they're probably going to need reading glasses for most of our patients is important. We all have patients who ended up having great reading vision without any glasses, but that's not a typical scenario for this lens. The second category is the multifocal or diffractive lens technology. Opposite to an EDOF lens, what this lens does do is both its strength and weakness. It does produce, most consistently out of all the lens technologies, the full range of vision, far, mid-range, and close-up, the full spectacle independence that many of our patients seek. It also does produce the dysphotopsia that we talked about, and I see it more of a feature than a side effect. So the way I explain it to my patients is that if spectacle independence, the full range of vision is what we want, this lens gives us the best chance to achieve that. However, it is associated with nighttime glare and halos and starburst, where overwhelming majority of patients with passage of time get used to it and it's not bothersome to them. I pause there and I listen and I pay attention. I pay attention to their body language and I listen to the kinds of questions they ask. And I think the conversation that comes after this description has the highest predictive value of finding out who will be a successful patient for this lens technology. Someone who's very risk averse, someone who does not want to compromise their night vision, who doesn't want to commit to the optical trade-offs of this lens will not do well with this lens. So I think the success with this lens most of the time is decided before you even do the surgery based on the kinds of questions and the conversation that you have with your patient. And that can come with experience. Some pearls about this lens. It is not forgiving to minor refractive misses and minor refractive error or residual astigmatism. So I would be very comfortable and have a plan to correct for that, whether it's laser vision correction or an intraocular lens exchange. It is also less forgiving to even minor ocular pathology sometimes. So even minor ocular surface disease or maculopathy can get in the way of this lens performing. So I would screen very thoroughly before you pick this lens for your patient. The kind of patient I would choose this for is someone who is first and foremost very motivated for spectacle independence. It must mean something to them to not have to wear glasses for their far and near vision. I'd say that's where I usually start. And this is someone who understands the optical trade-offs of this lens technology, particularly if they're use their eyes a lot at night. Let's say a truck driver at night, this may not be the best lens choice for them. Finally, the adjustable lens. The adjustable lens to me is optimizing for accuracy and adjustability over convenience and efficiency. You're committing to a refractive target before the surgery to a longer post-operative care where you will find that final target and adjust the outcome to that. There are two categories where I, in my practice, look at the adjustable lens as a primary choice. Category one are patients that I think by choosing the adjustable lens, I have a better chance at hitting my final target compared to traditional methods. So some examples are the extremes of myopia or hyperopia, high axial myopia or hyperopia, or patients that have had prior corneal refractive surgery, particularly those who've had multiple enhancements. We have formulas for someone who's had a myopic LASIK, for example, but if you've had a LASIK and one or two enhancements after that, there are really no reliable formulas to pick a lens for that patient. So I think the adjustable lens does do better for that kind of a patient and eye. The second category are patients that are unwilling or unable to commit to a final refractive target. So this could be someone who may want monovision, but they don't know their final near vision aim. Or someone who is open to monovision, but they don't want to commit to it just yet. So this lens does well for these patients. We always say that pre-operative surgery becomes the post-operative discussion. There's one category as a pearl I would recommend to stay away from, and that's patients with a cornea that has very high order aberrations that you think in your clinical judgment will get in the way of their final outcome. It's going to affect their final vision results. So common examples are a severe Salzmann nodule, advanced MAP dot dystrophy, limbal stem cell deficiency, or at times severe ocular surface disease. The adjustable lens at the end of the day is very effective at treating lower order aberrations, but not high order aberrations. So if you think those higher order aberrations will affect the final outcome, the adjustable lens is not a great choice. Said differently, if you wouldn't pick a toric lens for that particular eye, I would not choose the adjustable lens for that patient either. So in closing, as I go through a cataract consult and as I examine the patient and listen to them, in my mind, I'm creating a list of what's their optical tolerance, what are their preferences, what is the demands of their vision, what are their ocular comorbidities, what is their willingness to participate in the aftercare, what is their commitment, and what does it mean to them to have improved vision? Is spectacle independence something they value? And as I go through this list in my mind, I narrow down my strategy of lens choices to 2 or 3 before I make a final recommendation. And I think we're always going to have advancements in lens technologies and diagnostics, but the most important tool we have as surgeons is not the next lens or the next laser or diagnostic device. I think it's our ability to select the right patient for the right lens. Patient selection, I think, is our most valued and sometimes underutilized tool that we have in our toolbox. I'm so thankful that you listened this far. I would love to hear any questions you may have for me, and I wish you a lot of success in your practice. Thank you very much.